An English village. Once, not so very long ago, before the automobile, it slept in the countryside, its inhabitants isolated from the foreigners in the cities a few miles down the road. The men and women here bred and interbred and produced children who were equal before God. These are children of the egalitarian 20th century. But are they equal? Look at them. Brown hair, blonde hair, blue eyes, green eyes, short, tall. Theirs are characteristics passed down from a tight-knit group whose forefathers had bred here for centuries. Deeks with Deeks, Allen with Allen, Lawrence with Lawrence, Westhorpe with Westhorpe. But like their forefathers, these children are unalike. It's an inescapable fact that genetic characteristics are infinitely variable. Newcomers to the village, a young mother and her baby. Soon they'll be part of the village, but the mother knows that genetically she's different from most others, and the chances are that so is her baby. The results of the difference, this genetic chance, prompts the question, what is there to the phrase, the equality of man? This baby, Susanna Bridges, like any other, is the result of chance in human breeding. And we can say with what mathematical probability she'll be genetically different from what most people regard as the norm. But what is good breeding? Major and Mrs. Headley can trace their family tree for several centuries. They know a lot about breeding, but like most genetic knowledge, it comes from animals. The Headleys are Arab horse breeders. Mrs. Headley is a skilled breeder. She knows what makes for perfection in an Arab. And because she has genetic knowledge of her stock, she can breed for it. She can breed for whatever characteristics she wants.
Particularly the dished head, going into a fine muzzle, the big bold eyes, black, and set in the head very much like a gazelle. The very fine mane, which is almost as fine as human hair. This shows great quality and is very typical of the breed. The ears should be well-shaped, with turned-in tips.
The stud farm is the modern-day equivalent of what once existed in the desert, when Arabs bred animals to look good and to move fast, but to be graceful and behave well. Remarkably, the Arabs set out to breed an animal to live with them in their tents at night, and they succeeded. Some of their success was due to chance, but most was due to the skill of the breeder, his knowledge of the stallion and the mares. These horses are bred to standards, to look alike, to behave alike, all to be perfect in the Arab breeder's eye. In other words, to be equal. What's more, the Headleys claim they never, because of their skills as breeders, produced defective newborn animals. If it's so simple with animals, why isn't uniformity or equality more evident in man? And shouldn't every child have the right to be born like these animals, free from defect at birth? The answer is, of course, that these creatures have no free will. They are mated as people choose to mate them. Men and women more or less mate as they choose, and this can produce problems. Pat Bridges is the carrier of a single defective gene, a gene which means that there's a high and exactly predictable chance that her male child will suffer from the disease known as hemophilia. Inevitably, if men and women want to understand their own genetic makeup and why it is that Mrs. Bridges is genetically very slightly different from other people, they have to study animals. Geneticists usually study organisms which reproduce more rapidly than the horse. This mare is, however, particularly valuable because genetically she's not equal to most other animals. She's being cared for in the hope that she will produce offspring like herself, because she too carries the gene which worries Pat Bridges. The mare is being studied here at the Equine Research Station.
Well, she's a race mare. She's a thoroughbred. Now in foal, as you can see. She had 3 foals before she came to us, and 3 with us. The first colt foal she had turned out to be a bleeder, what we call a hemophiliac. And that must mean that the mare, in fact, is a carrier of this disease herself. And that's what interested us.
Anyone familiar with horse breeding and this horse's condition can say what its offspring are likely to be. Dr. Richard Archer.
So if you have a mating arranged, as it might be like this, with here a normal stallion covering a carrier female, then 4 things may happen. You may get, so to say, the normal half of the female and the stallion giving you an absolutely normal female. You may have the normal half of the female and the stallion giving you a normal male. Or you may get the affected part of the female with the stallion giving you another female carrier, or the affected part of the female converging with the male giving you a hemophilia affected foal. And it is just like that from generation to generation in horse and man.
There are obvious physical differences between a human baby and a filly foal. But how fundamentally, that is genetically, do they differ to a laboratory scientist? Genetics as a science has made enormous strides in this century, particularly during the past few years. Refined laboratory techniques have made it possible to grow cells separated from blood. In a sample of horse's blood, unlike in human blood, the red cells settle quickly, leaving the clear blood plasma on top. This is a delicate process. Any contamination might ruin it. It has to be carried out in sterile conditions. The white cells can be collected. To make sure they're present in the right numbers, they're counted electronically. Then they're put in a nutrient solution on which they can feed and grow. When they're put in an incubator and left for several days, the cells will go on dividing and multiplying. Only somebody with skill and experience can get it to work. At the right stage of the cell's division, they're put under the microscope. The chromosomes, the large structures which carry all the genetic information about the horse, can now clearly be seen. And they can be photographed and put into an order meaningful to a geneticist. He makes up what's called a karyotype by cutting out and pairing together chromosomes of similar size and shape. But what basically is the difference between the karyotype of a horse and that of a human?
Well, the strangest thing about it is that in the horse there are more chromosomes than there are in man. In man there are 23 pairs, and in the horse there are 32. Now, why there should be more in the horse than there are in man, I've simply no idea. But it is so, and it is one of those quirks of genetics and genetical studies to which one would very much like an answer.
One characteristic that chromosomes can show is difference in sex.
This is similar to the best of my knowledge in all mammals, certainly in man and the horse. One has 2 chromosomes concerned with the development of sex, the so-called X and Y chromosome. Now, here is a karyotype of a horse. Here are the chromosomes as they occur, spread out after a cell divides. Here they are, cut out from this same photograph and paired up according to the types. And you can see, I think, quite easily that there are, in fact, 31 pairs down to there. There's the last pair, the 32nd pair, is the so-called sex chromosome with an X and a Y, since this is a male. And that is not doubled. The Y in the male differs. Had this been a female, there would have been a second X chromosome looking just like that one.
I'm looking at a dividing cell grown in blood culture. It's a white blood cell, human.
Exactly as with horses, it's possible to take a sample of cultured human tissue and photograph the 46 chromosomes, 23 pairs. The genes on these chromosomes determine every characteristic of the human being. And fundamentally, the chromosomes will determine whether the human being is a he or a she. Dr. David Hughes.
In this normal human male cell, there's one X and one Y on 44 ordinary chromosomes. And one from each pair will have come from each parent. The same applies in other species, although the individual sex chromosomes will look a little different. Now, if this had been a female cell, one would have found there were 2 X chromosomes. So let us add another chromosome here to show what a female cell would look like, and there'd be no Y chromosome. And so the sex is determined by 2 X chromosomes in the female and an X and Y in the male.
Maleness and femaleness are easily recognizable. No doubt the genes which this woman inherited from her parents affected how rigidly she, as mother queen of the greatest European royal family, could dominate that family. But the influence of Queen Victoria's genes was more powerful than she would ever know. It so happened that one of her 2 X chromosomes was defective.
There's no doubt that Queen Victoria carried the gene for hemophilia on one of her sex chromosomes, with quite disastrous effects for most of her descendants. But fortunately, she had some normal children, including Edward VII, who gave rise to our present Queen, and her granddaughter Victoria, who gave rise to the Duke of Edinburgh, so that the present royal family are entirely free of the disease. The distribution of the gene in the rest of the family is represented in red, with the carrier females shown in small letters, and those affected by the disease, the boys, in red, large letters. A notable example was Queen Alexandria of Russia, who was a carrier, who gave rise to Prince Alexei.
Alexei, heir to the Russian throne, was typical of many hemophiliacs. An attractive, lively boy, his life became blighted by attacks of bleeding into his muscles and joints. His mother would become exhausted trying to nurse him back to health. Her child's hemophilia, some believe, left her at the mercy of Rasputin and spurred the Russian Revolution. This, a few years earlier, had been a happy mother and child. A single defective gene had turned life into a nightmare. But the X chromosome, which carried hemophilia to the crowned heads of Europe, also carries it to more ordinary folk. Pat Bridges was born in 1946. Susanna was born in 1975. And Susanna's great-grandmother was born in 1898. She didn't have her first ride in an automobile until she was 21. Mrs. Murray is, if you like, the Queen Victoria of her family. For some reason, a change took place in one of the genes on one or other of her sex chromosomes. There was no reason why she, any more than Queen Victoria, should have known about it. She married in 1916, and she and her husband are proud of their family.
This is my husband and I. This is my son, Tommy. This is my eldest daughter, Nellie, and her family.
Pat Bridges and her brother.
This is my next daughter, Molly, and her family.
One son.
And this is my youngest daughter, Rosie, and her family.
A daughter and 2 sons. All told then, 1 son, 3 married daughters, 2 female grandchildren, and 3 male grandchildren. Robert is her eldest grandson, born in 1951. Like the rest of the men in her family, he was a fine, healthy baby with every apparent prospect of growing up into a healthy young man. Then, when he was 7 months old, he did something to his knee.
I took him to hospital, and I saw the casualty officer, and they told me they thought he'd got an infection, and they would give him penicillin injections. And after about 2 days, he got huge mauve bumps each side where they injected the needle. And I saw the consultant that they brought to him, and he told me that he'd got an abscess in the knee. They had tested for TB joints, which was negative, and then when he got to 14 months old, he fell with a pencil that dug into the floor of the mouth and started bleeding. And I took him to the hospital, and they said that these things do happen with little children. It was nothing to worry about. And the bleeding went on for a week, and I was afraid to go to bed at night. I just sat up with him all night, and it didn't stop. And Robert was very, very pale. So I went back to the hospital, and they took him in, and after a few days they did stop the bleeding, and then they brought a child specialist to see him, and he told me that Robert might have hemophilia.
Well, it was blood transfusions all the time. You know, the shortest stays in hospital were about a week mainly. And it was just blood transfusions until plasma came along. And even when plasma came, I was still taken into hospital and given blood. But if that didn't work, they usually put you onto plasma. And that usually did stop the bleeding.
Robert's hemophilia was diagnosed in 1952. At the same time, Nellie's younger sister, Rosie, was beginning to have more than a passing interest in future generations. She was thinking about becoming engaged. And in 1955, she married a young greengrocer, John Swift.
And she said, well, find out whether I would have children the same. And I asked the doctor that dealt with the blood side of it what the possibility was, and he said, oh, chance in a million, tell her to go ahead and have a family.
So Rosie did. The first child was a girl. John, her second child, was born in 1958. Within 3 years, hemophilia was diagnosed. Then 3 years later, she was pregnant again. Not unnaturally, she was worried.
Yes, I was. And I went to my own GP, who the GPs very rarely see a haemophilic or have any dealings with them, so they don't really realise what life with a haemophilic is like. So when I said, you know, I was a carrier of haemophilia, he said, oh, well, that's nothing today. And when I went to the maternity hospital, I was told the same by the gynaecologist when I said to him, you know, I carried haemophilia. Oh, that's nothing. But then they didn't have to live with it, and they half of them don't even know what it is. So I was more or less just told, well, you know, get on with it, sort of thing.
Their third child was another boy, Paul. There was no real cause for concern till one day he had a slight accident. She and her husband, John, now began to learn in earnest what hemophilia was all about.
Well, up until that time, we'd had no proof. And he cut his finger and down at Rosie's mum's. And then he got his first bleed in was it his knee?
Yeah.
A bleed in his, internal bleed in his knee. And that was worse because we brought him back. He was out somewhere and we brought him back. And he was sitting in the van at the time. And he just cried and screamed with the pain all the way home and all that night and the next day. And I think that's when, you see, up until then we didn't really realise that it's not the cutting theirself that gives them the pain. It's the pain comes from joint bleeds. And the first joint bleed we ever suffered, it just broke your heart to see the kid lying there crying with pain and absolutely nothing you could do, you know. You just felt so helpless, you know.
I think I do get quite a bit of pain sometimes. Other times, sort of, well, by now I sort of know what it's like, and it's easier or something to put up with it now. Don't mind so much, but when I was about 5 or 6, I used to cry a lot when it was hurting and that.
So when she was a teenager, Pat Bridges faced this situation.
These are my grandparents here. And here we have my Uncle Tom.
Her uncle was unaffected. Her mother was a carrier of the hemophilia gene, making her brother Robert hemophilic. Her Aunt Molly was a carrier. So was her Aunt Rosie. She herself might or might not be a carrier. but every single one of her male cousins was hemophilic. One cousin had been sent to this English school, which specializes in the education of severely hemophilic boys. For much of the time, the boys here can live a normal school life with a normal school curriculum.
Set, go!
When you look at these boys, every one of them severely hemophilic, most of the time it's not possible to recognize that they are genetically unequal. Many of them are here because it would be impossible for them to live at home. At any time, their routine can be interrupted by a joint or muscle bleed, which puts them into the school sanatorium, often for days at a time. The result of a bleed into a joint can be extremely painful, permanently deforming, and crippling. The school's honorary consultant is John McCarty.
So how many bleeds do you think you've had in this knee this term so far, roughly?
8 to 10.
And how many weeks? We've been back 6 or 7 weeks, so that's more than one a week, despite having 2 transfusions a week just to try and prevent it. Okay, Mark. Right. Okay, Richard, let's have a look at this calf. Richard's just had a recurrence of a calf bleed. And the worrying thing with calf bleeds is that if left alone, if he doesn't get enough physiotherapy, if we don't keep this ankle mobile, and if it isn't treated enough, then his leg would be left, or his foot would be left pointing down in that position, which is, really would cripple him for life if we didn't take enough notice of it. Now, if we can just see, if I push this foot up, we'll find that it will become, just beginning to become uncomfortable for him. Where do you get most of your bleeds, Richard?
Elbows and knees.
Your elbows and knees?
Yeah.
It's a popular misconception that hemophilia involves the sight of an unstoppable flow of blood.
In animals, and in horses, which is my main concern, that have hemophilia, you have a chance to study what the disease has done to the animal when it hasn't been treated at all. Now, in humans, of course, you must treat everything because you must try to preserve life. But in horses, let me show you this, for example. Here is an ankle joint from the first case of hemophilia in a horse we ever saw. And that joint was very swollen when the horse came to autopsy. But you can see, I hope, that the bleeding is round the joint. In the joint itself, there's no bleeding at all. Now, in human hemophilics, nearly every case where there has been a swelling in or near the joint is treated by the orthopedic surgeon, usually by sticking a needle in. And that has gone through this area into the other, so that you then do not know, in the child, for example, where the bleeding arose at all. And it's from things like that in the horse that we have been able to offer some sort of assistance to the management of haemophilic children.
John, I wonder why he was so sick last night.
Not long ago, the life expectancy of an affected boy like Paul Swift was less than 20 years. Now the outlook has changed entirely. Current medical practice allows a nearly normal life at home. Paul can be treated locally and rushed to a treatment center. In fact, John Swift changed his job from grocer to cab driver so he would be available to take his son to the hospital on short notice. But what causes hemophilia? Why is it that the process of stopping blood flowing from a cut or in the joints doesn't operate in some people? How is it that the simple process of turning over in bed can turn Paul Swift into a cripple in severe pain? Dr. Catherine Dormandy.
Well, haemophilia is due to the deficiency of one of the things which causes blood clot. In the blood, we have a number of clotting factors, as we call these, and they're present in an inactive state, and each one as the triggered becomes activated, and then that one will activate the next one. So here we've got factor 12 becoming activated, and then activating factor 11, and that activates factor 9, and here factor 9 in the presence of factor 8, which is the one which is deficient in haemophilia, then goes on to affect factor 10. Now, if any of these is deficient, and in haemophilia it's factor 8 which is deficient, the process is blocked at that point, and the whole process is slowed up.
A few years ago, the only treatment for a hemophiliac was to give him a transfusion of whole blood. This is blood which has just been donated and has been centrifuged, that is, revolved at high speed. It's now possible to separate the red blood cells from the liquid plasma. It's this plasma that contains the essential clotting factor, factor 8. And from this liquid, it's possible to freeze out a precipitate, known as cryoprecipitate, which is very rich in factor 8.
That's what it looks like, and that represents the factor 8 from one person donating one bottle of blood. And this is the factor 8 that we can get out of it. Now, an average dose for a chap of my sort of size would need 8 or 9 bags. Now, the alternative, and this has only been available for the last year or two, is a commercial product. And here we have an example of quite a large stock of what is an Austrian product. As we can see, it's a freeze-dried concentrate, just a powder there. We make this up with sterile water for infusion, and that would represent 4 or 5 bags of cryoprecipitate. The importance of this is that we can reach very high levels of factor 8 using a relatively small amount of fluid. And of course, for home therapy, this is absolutely vital because we don't need a special freezer. An ordinary home fridge will do.
So, research during the past few years has made it possible for Mrs. Swift to treat John at home with cryoprecipitate kept in the deep freeze. It's now routine to the Swift family, and it will be part of John's routine for the rest of his life whenever he has a bleed. Mrs. Swift is now more skillful at finding a vein in John's arm than are most doctors. Her 2 boys are treated by different methods. Her other son can be treated at home or go to the hospital for treatment with a more expensive factor 8. The cost is significant. Some boys develop antibodies to factor 8, which means that they need extremely large and very expensive amounts.
When we do treat them, we have to give a high dose, both to neutralize the effect of the antibody and then a therapeutic dose on top. And in such cases, and we have several cases here, where we've had to use hundreds and hundreds and hundreds of pounds worth of material per week.
The cost, then, can be phenomenal. Here at Churchill Hospital, the Hemophilia Center attracts patients from a wide area of Britain and uses 1/3 of the whole hospital's drug budget for hemophilia treatment. And it's here that Dr. Rosemary Biggs and her colleagues like Dr. Rizza have made some of the most successful attempts to understand and therefore control the disease. Dr. Rizza.
If a carrier of hemophilia marries a normal man, and this is the usual situation, then the disease may be transmitted from her in the following fashion. She may produce a normal girl, or she may produce a normal boy, or she may produce a carrier just like herself, or of course she may produce a boy with hemophilia. Of course, the normal woman and the normal man, they don't bleed and they don't transmit the disease to any of their descendants. The disease is finished as far as they're concerned. In the case of the carrier, she will transmit it in the same way as her mother is transmitting it. In the case of the hemophiliac, the transmission is slightly different. When he marries a normal woman, all of their sons are entirely normal. A man with hemophilia cannot pass the condition on to his sons. So they're entirely normal and hemophilia is finished. They cannot pass it on to their descendants. In the case of the girls, however, all of the girls are carriers. They are obligatory carriers. They must be carriers of the condition because of the mode of inheritance.
Your hand, that's it. Good.
The same situation applies to all sex-linked diseases like hemophilia and muscular dystrophy. So when Paul Swift marries, all his sons will be entirely unaffected by hemophilia, and all his daughters will be carriers.
It's nice and quick.
He himself is known to be hemophilic because of the sometimes crippling effects of the disease on him. But it's possible to verify the diagnosis by testing for the amount of factor VIII in his blood. A sample of his plasma is taken, and using a sophisticated method, enough factor VIII is added to compensate for the missing factor VIII in Paul's blood. The time taken by his blood to clot can then be compared with that for normal blood. In this way, it's possible to obtain a measurement of the actual amount of factor VIII in his blood. But to prevent the disease, an obvious step is to detect female carriers of it. On average, a woman who carries hemophilia has about half the normal amount of factor VIII in her blood. Paul's mother, for example. But she also has in her blood a protein related to factor VIII called factor VIII antigen in the same amounts as a normal woman.
Right. That's it.
But when Rosie Swift first got pregnant in 1958, there was no way of measuring this antigen. She had no way of knowing, therefore, that she was a carrier of the disease until John was born. Then, in 1971, a method was discovered. It involved making a gelatin solution containing an antibody to the antigen in the woman's blood.
First of all, I take 2 glass slides and place them on either side of this U-shaped plastic formal, which gives me space in between the glass slides into which I'm going to pour my molten agarose. First of all, I clip the glass slides with those clips. I then take my pipette and warm it because the agarose will solidify unless it is sucked up into a warmed pipette.
The agarose is the gelatin-like mixture. It's this mixture that contains the antibody to the factor VIII antigen in the woman's blood.
I have sucked up my agarose, which contains the antibody to the factor VIII protein, and I now pipette it into the space between the glass slides.
It's now left to solidify. After about 10 minutes, the top glass plate can be removed and prepared for the patient's samples. Small holes are cut in it. Then samples of the patient's blood plasma are placed in the holes alongside samples taken from a normal woman. The next process is a standard piece of chemistry called electrophoresis. It involves putting the gel into an electric current by sticking a couple of wet filter papers to it.
I put on the lid, and then I attach the electrophoresis bath to the power pack. And then switch on the current.
The current draws the antigen up the plate, and it reacts with the antibody in the gel. A few hours later, this is the result.
If you look at the gel, you can see quite easily that it now contains several white lines, white precipitates, which have been brought about by the migration of the factor VIII protein in the wells out into the jelly.
In the 3 holes on the left is plasma from a normal woman. made more dilute in each hole. The central 3 holes contain plasma from a carrier of hemophilia, like Rosie Swift, diluted in the same way. The highly significant result of this experiment is that it shows that a normal and a carrier woman have practically the same amount of factor VIII antigen. But what's different is the amount of factor VIII itself. A carrier can have between 0 and 100% the normal amount of factor VIII. This can be measured by adding the missing factor VIII and measuring the time taken for samples of carrier blood to clot. In a normal woman, the amount of factor VIII and its antigens is balanced. But in a carrier, since factor VIII is often deficient, these experiments can sometimes make it possible to tell a woman whether she is a carrier. This stage of research had been reached in 1971, when Nellie's daughter Pat was about to get married. Because of their fear of hemophilia, she and her husband John had decided not to have children. But at her Aunt Rosie's recommendation, she went for the new test. It was positive. What did it feel like to know after years of uncertainty that she was a carrier of hemophilia?
I think relieved. I'd always sort of presumed that I was, but I was never absolutely sure. And I remember waiting for the results and thinking, supposing I'm not a carrier, and thinking wouldn't it be wonderful, but I think really all along I thought I probably was. And it just confirmed it, and I think it was relief to know that I was a carrier.
Relief perhaps, but also the beginning of a period of serious decision-making in Pat Bridges' life. And it was the beginning of a series of visits to London's leading hospitals. Now that the test had shown her to be a carrier, Dr. Dormandy could explain what the genetic consequences might be if Pat and her husband did decide after all to have a baby.
Well, I usually draw out a family tree for them, in which we represent females by circles and males by squares, and a woman, of course, has 2 X's, and if she's a carrier, we'll give her a blob on one arm, and the man is an XY, and he's normal, her husband. So if their first child is a girl, and she's going to get an X from the mother and an X from the father, and she'll be perfectly normal. The next one's going to be a boy, and he'll get an X from the mother and a Y from the father, and he's quite normal. So the next one's a girl, and she'll get this X from the mother with a blob on it, and the Y and the X from the father. So she's a carrier, and this boy, if he gets this X, will have hemophilia. If you look at this, there's one normal girl, one normal boy, one carrier girl, and one hemophilic boy.
The reason why a boy carrying the defective gene is affected by hemophilia is that the gene is carried on his only X chromosome. But for a girl carrier, one of her 2 X chromosomes is unaffected, and so she doesn't have the disease.
And of course, you could say that the chances of having a hemophilic boy were 1 in 4. But you have to be very careful to remind a parent that each time it's like the toss of a coin, and they could have 2 hemophilic boys running, or 2 carrier girls.
It was the summer of 1972. Pat and her husband had by this time spent a lot of time trying to decide whether or not they should have children. It was then that Pat was sent by Dr. Dormandy for genetic counseling with Dr. Jack Singer, an American now working in the pediatric research unit at Guy's Hospital.
We thought it over a lot, and we wanted children, and we just didn't want to have any haemophilic sons. Having grown up with haemophilic boys, I just didn't want to have any of my own because they suffer so much pain, and I just didn't feel I could give life to a child who was not going to lead a full, normal, active life.
Dr. Singer wanted to know precisely what the Bridges knew about their chances of having an affected child. And because of the recent advances in genetic research, he could tell Pat that it was now possible to test prenatally the sex of her child.
We took them through the test step by step and told her what the risks were to begin with of the test. Basically, there was no risk to her, but there was a risk to the fetus, which essentially was a risk of a miscarriage, which is very slight, but still a risk. And again, we drew this diagram for her and told her what the genetics were and what the possibilities were, and then what her options were, and then she would have to make, she and her husband, preferably both of them, would have to think about it and decide, A, whether or not she wanted the test, and if she did, whether or not she wanted to have a termination if it were a male.
And we then decided that if we could have daughters, we would certainly like to try and have one.
Now, if I could just have a look at your tummy.
By the autumn of 1973, Pat was pregnant and had again made the journey from their home in Suffolk to the London Teaching Hospital. She had been referred to Tim Coulthard, who was regularly carrying out amniocentesis like this one on women in or about their 16th week of pregnancy.
There we are, up to there. Good. Right, now we have a spot of local. This is just some cold on your tummy.
Yes.
All right, wait for it.
The test is now routine in many hospitals and is automatically offered to all pregnant women over 35. The first stage is a local anesthetic.
Stings a little bit.
It's a simple procedure with a very slight risk to the fetus. Amniocentesis is most often used to determine if the fetus has Down syndrome or Mongolism.
Can you feel that at all?
No, hardly at all.
Good.
The procedure uses a hypodermic needle to draw off a sample of the fluid that surrounds the fetus in the womb.
Back in a moment. I'll warn you when. Try and let your tummy go as loose as you can. Good. That's it. Now, coming now. That's it. Some of the fluid coming now.
This fluid is the source of what a few years ago would have been an inconceivable amount of information about the state of the baby in the womb.
That's it. All finished.
The vital piece of information, as far as Pat Bridges was concerned, was that it might be able to tell her the sex of her child.
Good.
The procedure requires speed, skill, and good luck. The cells from the fluid are cultured, put into a nutrient solution in the hope that they will grow. During the past 5 years, techniques have been improved so that this is now no longer the chancy experiment it used to be. The cells grow on a small microscope slide. If all goes well, the process will be complete in a couple of weeks. This essential period, when the cells divide, is a difficult waiting time for a pregnant woman. When the cell's growth is complete, the slide is stained with a dye to make the chromosomes visible. If all does not go well, and if the process has to be repeated, it could be too late for the woman to have a safe abortion. Now, just as it's possible to get pictures of the chromosomes from tissue of the adult horse or human, it's possible to get pictures of those of the unborn child and arrange them in a karyotype. Professor Alan Emery.
Now, here you see is a karyotype, the layout of the chromosomes of a normal female with 2 X chromosomes here, and then compare this with a male who has, as you can see here, an X chromosome and a little Y chromosome, and by looking at the amniotic fluid cells after they've been grown, we can sex the fetus. And since there's a 50-50 chance that a male fetus will be affected, then the mother could be asked, would she like a termination because of this?
For the woman carrier of hemophilia, this is the most important information she needs. But there are other defects detectable in the amniotic fluid. It can give information about spina bifida, metabolic disorders, and chromosome damage.
You can see that this is a male with an X chromosome and a smaller Y chromosome. And I want to draw your attention to the fact that here you see there's just two 21s. Now, if the child had Mongolism, then you see that here's a boy who had Mongolism and has an X and a Y chromosome. You see he has three 21s. And this is possibly one of the most common indications for amniocentesis at the present moment, is in mothers who are over the age of 35 or 40, where they have this increased risk of having a child with Mongolism.
But there was no complication in the case of Pat Bridges. The information required from her amniotic fluid was simply the sex of the baby she was carrying. The 3 weeks of waiting were difficult for John and Pat Bridges. They had an agonizing decision to make. If the baby was a girl, there was no problem. If the baby was a boy, there was a 50-50 chance that it was hemophilic, meaning there was also a 50-50 chance it was normal. They had to make a decision to risk aborting a perfectly normal boy. On the 8th of January, 1974, a telephone message came from Guy's Hospital. It was a boy. They'd already made up their minds to terminate.
This was thought out quite clearly some time beforehand. Even before we had the counselling, we thought if we had the option, what decision would we take? So we knew pretty well beforehand.
But within months of that news, Pat told John that she was pregnant again. Did she have mixed feelings at what for most people would have been a happy event?
Very mixed feelings at first. My reaction was to keep very quiet about it. Whereas the first time I became pregnant, I wanted to shout it to the world, And the second time, I kept very quiet about it and tried to be very optimistic. And after the amniocentesis, and it was found to be a daughter this time, I was just so happy the day I received the news. I went straight out and bought lots of pink blankets and things.
The second amniocentesis told the Bridges that this time Pat was carrying a girl. And so in June 1975, Susanna was born, a perfect girl. Perfect as far as it's known, until she herself decides to have a blood test to find out whether she's carrying the gene for hemophilia. But the decision to terminate the life of a male child, which has a 50-50 chance of being normal, is not without controversy. The issue is clear. These boys survive, thanks to advanced research of the last 20 years. The cost to society of keeping them alive is enormous, as is the strain on the family that has to look after them. Their suffering is an unhappy sight for the rest of the family to witness. Would it be better if future generations of hemophiliacs were prevented by abortion, accepting the inescapable odds that for every hemophiliac whose life is terminated, so is the life of a perfectly normal male fetus? Members of the medical profession must put the facts before every pregnant woman who carries the gene for hemophilia, but they're reluctant to give advice. What advice might a doctor give to his wife if she were a carrier? John McCarty is himself a Catholic.
No, I do feel that I would advise her to carry on in the pregnancy because I do feel that hemophilia, the treatment of hemophilia, the coping with hemophilia is improving so much that I would advise her to carry on. However, if she had a hemophilic brother who she'd seen suffering enormously over 20 years, perhaps she would have totally different views.
So to be clear, the advice you would give to her would be based on your medical experience rather than a religious view?
Oh, very much so, yes.
I think that's a decision for the woman herself and her husband. If she, for instance, is the sister of a hemophiliac, and many are, then she knows much more about hemophilia than I do. She's lived with it, she knows the problem, and she knows herself if she can face up to having a haemophilic son like her brother, with his problems and with his pain and discomfort, and also with the disruption of family life, which the birth of a haemophilic son
Which can be very great.
Which can be very great. She knows this much more than I do. I think perhaps she's better placed to make the judgment than I am.
Forgive me if I push the question too far. What advice would you give to your wife under these circumstances if she were a carrier?
I don't think I would be her doctor. I would send her to someone else, because I think I would be in the situation of being in on the discussion as a husband as well as a doctor. I think it's an impossible situation. I would send her to someone else to be advised.
Is the situation altered any by the fact that in the case of a sex-linked disease like hemophilia, for which there is now an improving and continually improving method of treatment, that there is less of a case for termination of male fetuses?
Well, personally, I think that severe haemophilia is still an extremely unpleasant disease. Now, I know a lot of people with haemophilia well, and I don't actually know anyone who wishes he'd never been born. But I think that it is a very, very nasty illness, and that if it can be prevented, then it should. People should be free to prevent it if they want to.
Our generation has already been affected and will increasingly be affected by amniocentesis. Hypothetical questions were no less a problem to the Victorians than to us. But suppose amniocentesis and a sex test in pregnancy had been available to Queen Victoria and her descendants, followed by termination of male fetuses without religious objections. The effect on Europe then might have been dramatic. Some might think catastrophic.
For example, Edward VII could have been terminated as a male fetus, resulting in the present side of the royal family not existing, and so that we would not have had, then, Queen Elizabeth II. However, Prince Philip could still have been born because he was descended through a normal female line through Victoria. If amniocentesis had also been offered to Queen Victoria's daughters and granddaughters, so that they could have terminated male fetuses, then these affected males, notably Alexei of Russia, then would not have been born. The Spanish royal family could also have been extensively affected if Victoria Eugenie, as a carrier, had chosen to terminate Juan as a male fetus. Then the present King of Spain would not have been born.
Nobody, therefore, should underestimate the effects of present-day genetic research. It's now possible to recognize prenatally dozens of genetic abnormalities whose drastic consequences can be predicted. A knowledge of the genetic heritage of a woman carrying hemophilia can prevent a lot of suffering. There are some very far-reaching steps we might consider. Should, for example, all young couples be genetically screened before they're allowed to marry? Professor Emery.
I'm sure eventually that many other diseases are going to be screened for before people get married. So the problem is, if you leave it till people do get married, it's quite possible that a couple may have already started a pregnancy without knowing that one of them is perhaps carrying a serious disease, a genetic disease, or the likelihood of having a child with a serious genetic disease. And for that reason, I think it's better to screen before people do get married.
By the time a baby is born, or in many cases when it's in the womb, it's too late to prevent an inborn error. All normal babies, like this one, are screened at birth. Here it's for an inborn error called phenylketonuria. But if the result is positive, it is, in a sense, an admission of failure to prevent the disease. There are two possible solutions. One, the ideal, is to find the cause and prevent the disease. The other would be to submit ourselves to genetic screening before bearing children. Pilot schemes exist. This is a computer terminal at the Edinburgh University Human Genetics Department. It's part of their genetic register. This contains genetic information on families at risk of diseases such as hemophilia and muscular dystrophy. When girls recorded in the computer reach childbearing age, information of the risks they face can be released to them. And here, for the future, is the British Medical Research Council's Cytogenetics Unit computer, which it's hoped will automate the recognition and recording of large numbers of human karyotypes. There is no comparable unit in the United States. But chromosomes, with all the detailed medical information they can give, are very personal pieces of property. Whether we as individuals are willing to have this sort of information stored and available is a matter we as individuals should think about. One could argue, in one sense, that it's a pity we're not like animals. Without recourse to computers, a horse breeder breeds the characteristics she wants in a horse with phenomenal success. But horses don't have the free will to breed as they choose. The forefathers of the village bred as they chose, and they bred themselves problems. But they also bred that wonderful variability, which gives human beings their uniqueness, their skills, their courage, their deviousness, their creativity. And variability means that there's no chance of the children of the village ever having been born equal. Genetically, there's no meaning to the phrase. But every child does have the right to be born with as few imperfections as possible. And this is the aim of prenatal diagnosis. But there should be no mistake that the more efficient it becomes, the more unforeseen moral problems it will present to ordinary people. In Pat Bridges' lifetime, it's become possible to detect the sex of her unborn child and so present her with the heart-rending choice of abortion. But as a result, she's ensured that Susanna was born free of imperfection. Free, that is, except that there's a precisely 50-50 chance that she carries the gene for hemophilia. The hope is that by the time she's her mother's age, not only will it be possible to detect it in the womb with 100% certainty, but that its genetic cause will have been discovered and it can be eliminated.